All right, everyone. Good morning. And today it's my pleasure to welcome you to Grand Rounds. So I'm going to be introducing our speaker for our 2026 Jack T. Reeves Memorial Lectureship. It is Dr. Trevor Nydam, who's going to be speaking on the innovation in transplantation, the University of Colorado legacy. So this lectureship was established in the honor of Dr. John Jack T. Reeves to reflect his multidisciplinary approach to science and medicine. Dr. Reeves was a renowned physician scientist here at the University of Colorado, internationally recognized for his work in cardiopulmonary physiology and pulmonary vascular disease. And just as importantly, he was deeply committed to mentorship and to building bridges across disciplines, values that continue to shape us today. So it's especially fitting that our speaker today embodies those same principles. Dr. Nydam has been an integral part of the University of Colorado transplant program since 2010, when he came here first as a transplant surgery fellow. Over the past decade and a half, he's helped shape and elevate this program into one of the nation's leading centers for transplantation. He currently serves as professor of surgery, chief of the Division of Transplant Surgery, and executive director of the University of Colorado Transplant Center. He is widely recognized for his work in liver transplantation, particularly in living donor liver transplant, robotic-assisted transplantation, and normothermic regional perfusion for deceased donor organ recovery. His innovative approaches have advanced surgical technique, expanded the donor pool, and improved outcomes for both transplant recipients and living donors. His research focuses on optimizing transplant processes and improving patient outcomes, including clinical trials in ex vivo liver perfusion and strategies to improve renal function following liver transplantation. He has been highly productive academically with more than 100 peer-reviewed publications and multiple grant-supported studies. But what truly stands out is the impact of his work on patients and the program as a whole. His efforts to improve liver allograft utilization and develop minimally invasive approaches for donors have directly translated into better outcomes and broader access to transplantation. At the same time, his leadership has helped foster a culture of excellence, collaboration, and innovation within the division. So please join me in welcoming him for today's Grand Rounds.
Wow, thank you for the introduction. Thanks, Vineet. Jen, thanks for the opportunity to come and talk about transplantation, talk about the contributions that the University of Colorado has had to the transplantation field in general. And I really want to talk about sort of the mentality that we're going to have to continue to have in the transplant center here. I don't have any disclosures. In the 60s, liver transplantation was essentially invented here at the University of Colorado. Tom Starzl, he was quite the personality. Dr. Teitelbaum can attest to that. There's probably several people in the audience who worked with him as he built liver transplant through the 60s and into the 70s. It's his mentality that set the stage, I think, for innovation in transplantation in general, but certainly the culture and what we want to emulate here as we continue to push things forward. He trained my mentor, Igal Kam. Igal Kam trained me, and there are many aspects of the things that he did that are still evident in what we do today and how we do these operations. We have a lot of the original works that led to the publications that really invented this field in the 60s and the 70s. We have a durable answer to end-stage liver disease because of his work and the people around him and the team that supported him. In the late 90s, the gathering up at Breckenridge that we have every year, Controversies in Transplantation, has led to a lot of innovations over the last few decades. The MELD score, the idea of the MELD score was originally the product of conversations that happened up there during this meeting. And then Dr. Weisner went back to the Mayo Clinic and developed the MELD score. We're very good at predicting end-stage liver disease and the mortality associated with it. Because of the work of Tom Starzl, we're able to flip that mortality of 80% at 3 months completely over into an excellent 1-year survival, graft survival, and an excellent 1-year patient survival. Liver transplantation is the only effective treatment at this point for end-stage liver disease. It was very clear that there's a significant survival advantage even for low to moderate MELD patients. So we have an answer. We have a durable answer. Unfortunately, we don't have the means to proceed. And so if you look at the 2024 wait list, we've added, and this continues to be the case even 2 years later, we've added many more patients than we're able to transplant. Unfortunately, thousands of patients have to come off the list every year because we're unable to transplant them, just simply because we don't have the means to do it. So that puts us as a transplant center, as transplant hepatologists, in a tough situation to care for patients, but not have the answer to transplant our lower to moderate MELD patients. So there was a patient of Greg Everson back in the late 90s, a PSC patient, who had a sister, and there were some reports of a living donor liver transplant success at the University of Chicago in children. And the sister of one of our patients here kept pushing our staff to consider adult-to-adult living donation. My mentor, Igal Kam, and Michael Wax performed the first adult-to-adult living donor liver transplantation in the United States. So in continuing with the theme of innovation and pushing the field forward, addressing problems that we see every day, this team, including Greg Everson, put together the protocols and put together the run-in and to make sure that they could safely do it, and they executed it. The patient's done extremely well. This, again, changed liver transplantation in the United States and in the world. The initial cases you see there on the right in the early 90s were essentially adult to child. When reports of our first case that occurred in the late 90s showed that this is it's a safe thing to do in the right hands, it significantly changed our opportunity to take care of our low to moderate MELD patients. And you can see that after this report went out, there was a significant increase in the number of cases that occurred in the United States. So from the late 1990s into the early 2000s, it essentially went from 0 adult-to-adult living donor liver transplants to about 500 per year. This is an option. And how do we know it's an option? We can look at the large data that we have, reviewing the previous living donor cases that have happened in the United States. And we can compare the living donors who, recipients who get a transplant, we compare them to the patients that stay on the list. There's a significant survival advantage. So once again, our group looked at these data, and we found that there's a significant reduction in mortality and a survival benefit obtained by doing living donor liver transplant. Down to the MELD of score of 11, there's a significant mortality, decrease in mortality. And that's at a very low to moderate MELD. If you look at the higher MELDs, obviously that's significantly higher and a much better mortality advantage there. It's a survival advantage with living donor liver transplant, again, in low meld, it's obvious. When you get a few hundred days out from the transplant, there's a significant advantage. And if we look at the higher meld patients, that advantage is huge. Life years follow suit. So we saw that there was a significant increase after we did the first case here in the United States. That pushed the number to about 500. Why, over the last couple decades, has that number essentially stayed the same? Again, it's a very small proportion, and we're still only doing about 500 cases per year. It's a very small percentage of all the living transplants, all the liver transplants that we do. Why is this still not utilized more throughout the United States? It's a difficult operation to do, the donor hepatectomy. You need to have a long mentorship and a long road into it. But there are some significant hurdles that we need to address. Is it the risk to the donor? We're taking a perfectly healthy person to the operating room for an operation that they don't need, okay? Ethically, that's something that when you take the recipient into account that we can work through, you need to have a very clear conversation with the donor. That's something we do every day here at the University of Colorado. I believe that obviously this was a very difficult thing for our program and a handful of other programs to go through. This is probably the worst day of my career when, as a fellow, a few months into my fellowship, I had to drive in and call my mentor, Dr. Com, and let him know that our donor had arrested 3 days post donation. I'm very aware of what it means to be a living donor, what the risks are. But we take risks like this every day. So I believe that the real disincentive to moving forward with a higher volume of living donors has to do with our calendar, our family, and our day-to-day lives. Okay, this is my crew. There's my wife, Jane. She's a pediatric cardiologist. She works next door. She's also the president and CEO of Nydam Enterprises. And so to pull her or myself out of the operational makings of our family is a significant thing. This, I believe, is the real disincentive to a lot of people moving forward, okay? The Apple Calendar, the Google Calendar runs the show. Removing the disincentive of lost wages is also something to be considered. But I think as a field of liver transplantation, and more specifically the professionals that are in living donor liver transplantation, we need to make the operation more tolerable. We need to make this something that people can consider and then move back to their normal lives as quick as possible. Doing this operation with an open incision is a significant hit to these healthy people. We make an upper midline incision. We are changing their core strength significantly over the next few months. We significantly take down their functional status, and it's right in the respiratory mechanics, so these are very symptomatic. If we could do this operation through 4 small incisions and recover it through a small fan and steel incision that has very little impact on their functional status, I believe that this could be something that would be much more tolerable, get people back to normal life, get them back to work much more quickly. That's what they found in Saudi Arabia. Our good friend Dieter Broering, the conditions there allowed them to move forward with this type of operation very quickly. And he reported his series of 500 patients over the course of the late 2018 into 2022. He proved that this is a very safe thing to do. So if we're going to bring that back to the University of Colorado and provide that to our list and our potential living donors, we need to make sure we have a safe run into that. We need to make sure we've done it thoughtfully. And he's proven that it's a safe thing to do in the program out there. So how can we bring that back here? How can we innovate and continue to push the field forward? I think you need field strength in both robotics and in living donor liver transplantation. Okay, so we had field strength and we have field strength in living donor liver transplantation. We started it here at the University of Colorado, and we've been in one of the highest volume centers since that time. We have surgeons that can use a liver like this with segmental outflow venous system, okay? You can see here on the right, there's 3 right hepatic veins dumping into the cava. And then the segment 8 vein that's going high into the middle, the army green one there, okay? This is a liver that we use. There's not a lot of other programs in the country that would consider using this. We use this safely. We've reconstructed it, and it's something that you can do. It takes a real team to go ahead and do this operation, make sure that our evaluation of our donors is sufficient, make sure that we have all of the details taken care of. So it requires very high functioning coordinators. Jamie Chisek is the heart and soul of our program, and her and her team and what she does every day makes it possible for us to consider difficult cases, ones that might be a little bit more complicated. And so we have the security of doing that. It also requires an amazing partnership between the surgeons and the medical staff. Okay, you need our transplant hepatologists, Jay and Mike Chris, and all these, and Whitney Jackson are the absolute backbone of the program. Okay, so you need a medical director that is willing to overcome all kinds of obstacles that might be getting in the way of you actually doing living donation and making these things happen. These are 2 gentlemen that essentially told us that we don't have access to the operating room for a couple of our cases. Field strength and robotic assisted transplantation, okay? The field, or essentially the field of robotics moving into the operating room has been slow and steady, but it is definitely picking up speed. It's done well in surgical fields where there are a lot of operations that maybe the stakes aren't so high. You're not working with technical vasculature and doing that. So it's late to robotics. So if we're gonna consider doing a robotic donor hepatectomy, we need to build field strength in our robotics program. This was a difficult thing to do. It took a very focused effort from my junior partner, Thomas Pashak, who trained as a urologist and then did a transplant fellowship. So he had some early experience, a good experience in robotics. And so we were very deliberate about trying to find cases that could help our experience. So you can see over the last 5-6 years, we made a concerted effort and we did that. A lot of these operations were donor nephrectomies. We were taking out kidneys that no longer worked. We had very difficult redo operations. And so there were not a sort of a lot of low acuity operations that we could use to develop our skills and also develop the team. But persistence paid off. You can see here that we increased the number of kidney donors that we did robotically over the last few years. I think we're up to now probably 60 to 65% of our living donor nephrectomies being done robotically. Kidney transplant, the actual recipient operation, I think is something that we're very proud of. We are a leader. We are one of the 2 to 3 programs in the country to be able to offer that to our patients who had contraindications of kidney transplant. We are transplanting patients who have a BMI of 50. That is not an operation that you can do open. And so here at the University of Colorado, the work of Tom Pashak, going out to the other programs that are doing it, see how they do it, and bringing those skills and that program, the challenges that that program has already had, their successes, understanding what made a successful program. He brought those details back to our program here, and we were able to increase our field strength in robotic transplantation. We've now done over 100 robotic-assisted kidney transplants, okay? I think we are second to only to Cleveland Clinic in the United States. So that's another area where our innovation and really pushing the field forward to address a problem. We had a population of patients that didn't have access to kidney transplant, and he wanted to change that. He also was very good to me. I was his mentor in many ways. I taught him how to do liver transplant. I taught him how to do kidney transplant. And then when we realized that we wanted to develop a robotics program, I had to humble myself, and he taught me how to be a robotics surgeon. So it's an example of seeing a problem, trying to develop a way to address it, and then having the teamwork and the relationships to get that done. So with robotic field strength in hand and living donor liver transplant field strength well in hand, that allowed us to go to Saudi Arabia and operate with Dieter Broering and his team. I went there for 2 months. Tom went for 2 stints for several weeks as well. And we were able to observe how they did things. We were able to learn from their mistakes. And in order for us to safely bring this back to Colorado, we were very fastidious about all of the details. So on the left there, you see that's operating room number 7 in Saudi Arabia. We took back everything that they did and took it to our room, room 37, which is probably 100 yards behind me, and emulated everything that they did. There are huge advantages to doing this operation robotically. After I dissect out the vessels, we can gently occlude the vessels going to the allograft side and occlude them, and then you can see exactly where I need to come through the parenchyma. There are huge advantages to doing this operation robotically. It is a better operation for the donor and the recipient, as we'll see. It also allows me to look at the hilar plate. The biggest problem that we see in our recipients with living donor liver transplant is problems with the biliary anastomosis, bile leaks, and strictures. This allows us to see exactly where the bile duct is, essentially have a live cholangiogram that we can go to during the operation. We know exactly where to divide the ducts. You can see on the right, there's a complicated duct with 2 ducts going to the right, and it allows us to have much more security in making this division than we had prior. And like I said, if we know exactly where we can come through the parenchyma, then we can come through the parenchyma in such a way that we don't encounter the big vessels, and when they are there, we're able to see them. This is us being very patient and moving through the parenchyma, and the blood loss is significantly less in this manner than with the open operation. Again, we're able to use the 10x magnification. This is the structures going to the right lobe, which is the graft side, which is off to the looker's left there. This is us dissecting out the right hepatic artery, which is in the center there. The blue structure in the back is the right portal vein. And then that structure that I'm trying to divide there up on the right, that is the right hepatic duct. And like I said, when we divide the right hepatic duct, this is the most difficult part of the operation. And again, it allows us to do this with much more security. We can check the anatomy over and over and divide it. So we were able to take an operation that patients were typically in the hospital 5, 6, 7 days, change it to something that we can reliably tell these people that they're going to be out of the hospital in probably 3 days. Back to a functional status. It used to take almost 2 months prior to a lot of people going back to work at some manual labor. We had patients go back to skiing at A-Base in 3 weeks after this operation. So this has essentially changed the commitment that a living donor needs to make when they say that they want to do living donation. We've now done 46 robotic-assisted donor hepatectomies. The children's program, their list is backfilled fairly quickly, but we're able to consistently transplant their list and take care of the kids over there. We have partly because of this program, but partly because of our overall program and the culture here in Colorado, we have a very large volume of non-directed donors that come forward, and they take care of the list over there at Children's. And it required some special donors, some people that have come forward to be the first donors in each. The lady on the left was our first donor. She jokes that she felt like I was proposing to her when I first asked her to be our first case. But she's a very high-functioning previous CEO, and she took on that challenge with a lot of energy, and she's a huge advocate for us. The lady in the middle is our first right lobe donor, and then the gentleman on the right donated to his daughter, who you see there, and he was able to go over and be at Children's Hospital the next morning. This is not a program that belongs to me. It's not a program that belongs to Tom, the surgeons, or the physicians. This belongs to our whole team. So this is the operating room staff. To build out a program like this and do it safely, it's important to make sure that they have ownership, to be very inclusive in the process. Their ideas, their concerns were all very important. And I believe that our success, both in the outpatient setting and the operating room setting, is definitely dependent on the ability to bring everybody along in the process. So, you know, these individuals own the program as much as anybody. Psychological safety in the operating room, in the selection committee, and everywhere we make big decisions and big moves on a program like this is very important. Our experience with 49 donors up to this point shows that we have had excellent outcomes. We've had no major complications, no returns to the operating room. Our blood loss is extremely low. No major biliary complications in the donors or the recipients. We've had one graft loss in the recipient side, but it was just due to recipient issues and not necessarily the donor. And so when we look at the large volume of cases that were done in Saudi Arabia, it's clear that this is the future of this operation and the future of living donor liver transplant. It's better for the recipient. There's less complications on the recipient side, as well for the donors. Now I'd like to change gears a little bit and talk about another example where we had some challenges with our liver program, and we had to respond and adjust to deal with them. In 2020, deceased donor allocation changed significantly. And this was done to go away from the donor service areas and move more towards concentric circles around the donor hospital where the donor was. And this really prioritized using DCD donation throughout the country. That put us at a relative disadvantage. Areas that had a larger metro area and a larger population had more access to brain dead allografts. Being in the Denver metro area with not a lot of other large cities around us within those 500 nautical miles really put us in a position where we had to find a way to use DCD allografts, or we were going to have a significant decrease in the number of cases that we did. So let's review the DCD recovery. If a donor is declared brain dead, they're declared dead, and we can take them to the operating room with support while they're intubated with a perfusing heart and essentially a much more normal physiology. And we can recover those organs, and the ischemic hit to those organs is minimal. And that goes for thoracic as well as abdominal. When we recover a circulatory death donor, we have to wait for the donor to pass. There's a relative time of decreased perfusion and ischemia, and it damages the abdominal organs. That creates a scenario where, with a standard recovery, like you see here, we recover that organ and put it in the cooler and preserve it at a time where its physiology is, it's very inflammatory. It's at the point of maximal injury, and that's where we try to slow the metabolism. In many cases, we didn't know if the allograft was going to work until we sewed it into the recipient, right? So that really decreased our ability to use DCD allografts. We had arbitrary time cutoffs. We had to be very conservative. And in many cases, the injury to the bile ducts during that recovery, we essentially traded out one chronic disease for another. Ischemic cholangiopathy is a difficult thing to deal with. So there was a big limitation on the allografts that we could use. They typically had to be less than 40 to 50 years old. The warm time from the time of withdrawal care to the time that the organ was recovered had to be less than 30 minutes for liver, and that significantly decreased the utilization. If there was a way to allow the organs to recover prior to actually procuring the organs and recover from that initial injury, they would likely do better. So there were some data out of the UK and Spain that showed that if we placed the abdomen and the chest on an ECMO circuit, on a bypass circuit, after the donor had passed, and then we placed them on the circuit, and that would give us a pump run where this would allow the organs to recover prior to us procuring them and putting them on ice. Some programs developed up in the northern UK, down in Cambridge and in Spain, and the data showed that this significantly changed the phenotype of these allografts, and it ameliorated the biliary complications that are essentially the Achilles heel of DCD recovery. And so the data out of Spain and the UK looked very good. So we went to Scotland in Edinburgh and learned this technique from these guys early in their experience and wanted to bring it back to Colorado. While the abdominal circuit or the thoracic circuit is on pump, we can follow lactates, we can follow enzymes, we can look to see if the liver's making bile, and that significantly changes the phenotype of that liver. It helps the kidneys, and it allowed for heart and lung recovery in DCD as well. So this was a significant change. I came back and we really put together the team with the hospital, the OPO, and started to build the process of doing it, developing this program. At that time, Jordan Hoffman was recruited, one of our CT surgeons was recruited from Vanderbilt. He was a leader in thoracic recovery of DCD organs using normal thermic regional perfusion. And very quickly, we became one of the leaders in the United States at this recovery. This significantly changed our practice at a time where we lost access to brain dead allografts. And it essentially changed DCD recovery in the United States, and we followed closely behind what they were doing in Europe. This allowed us to have much more liberal warm ischemic times. When we were looking at allografts, we could use allografts up to 60 and 70 years old. It allowed us to do much more DCD liver transplants. And the United Kingdom risk score was something that we used to really decide whether or not we could use a standard recovery allograft. Very quickly, we started using allografts that were covered with NRP, that were previously considered futile and not usable. We were taking these allografts and we were using them in retransplants. We were using them in very much more risky recipients, and it changed our ability to take care of our list. DCD liver transplants had a high transfusion rate. They had a high take-back rate from the SICU back to the operating room for washouts, and a lot of these things went away. The length of stay went way down, and it changed our practice here significantly, as well as the utilization that Donor Alliance sees. Our program essentially brought Donor Alliance to the front of the OPO metrics. They're a tier 1 program, and that's largely due to our program here for normothermic regional perfusion. When they would show us their data, it was very clear that this was driving their DCD heart utilization. Through 2023, 24, and 25, they were #1 in the United States. Same with liver utilization, as well as a very high rate of DCD kidney utilization. They had an organs per donor ratio that was the same as brain dead donors. So this allowed us to not only maintain our volumes both in liver and lung, but actually increase them at a time when a lot of other programs saw a decrease. So again, this is another example of us as a program seeing a challenge and putting together a program to address that challenge. This is something that we will continue to do. It's something that we've been doing for a long time. It's important that we bring in the right people. Transplantation is truly a team effort. The communication and between the hospital and the school of medicine is extremely important. The teamwork between the medical side and the surgical side is something that we all enjoy very much, and it's vital to what we do, right? Our hepatologists, our pulmonologists, our cardiologists, and our nephrologists continue to be the best transplanters in the country, and we'll continue to work together to make sure that the University of Colorado continues to innovate. So with that, I'd like to open it up to a discussion. Any questions? And I'd like to hear what you have to say.
Thanks. That was a great overview. So I'll go ahead and open it up to questions from the audience.
Trevor, great talk. Every time I hear it, I learn something new, so thank you. You mentioned this briefly, but I think it's helpful to have maybe a bigger discussion on it. Mm-hmm. How did Saudi Arabia get so far ahead in the robotic surgery space? Like, what happened there? What was the cultural issue there you alluded to? And are we still collaborating with them in terms of growing our program? And what does that look like going forward?
Yeah. So the real disincentive to being a living donor, I think, I described with pulling somebody out of their normal life, taking them out of their job, worrying about lost wages, worrying about lost ability to help, the family and the whole enterprise move forward. In Saudi Arabia, there's a large population of what's called middle-class people who don't have those issues to deal with. A lot of them don't have jobs. So the financial situation in Saudi Arabia is very different. There's also, up until recently, for religious reasons, they did not want to use deceased donors. So they're completely dependent on living donation. And the legal climate is very different there as well. So when I went there and operated for almost 8 weeks, I didn't even have to get malpractice insurance because it's just not a thing. So the regulatory issues that we might have here to move something forward that's potentially risky, it just doesn't exist there. If you have a family member who has, let's say your father had end-stage liver disease, and you ended up being a donor, there was an immense amount of honor associated with that. You were essentially a made man after you did that. And so the culture is very different and the opportunity is very different. That's not something that we can replicate here. So, I came back and I was very excited about these new skills and having us build this program here. But we still have a lot of things that get in the way of people coming forward to being a donor, even for somebody that they care about. And that's something that Jay and Whitney and Mike, Chris, and everybody we work with every day.
One thing that struck me is, there's always still that large gap in kind of the need and the organs that we have available. Are there other things looking forward as opportunities to kind of decrease that gap?
Yeah. I think if somebody has a very high MELD and they're very sick, we're good at getting them transplanted fairly quickly because, their priority goes up on the list and we can do that. The challenge that we have in liver transplant is taking care of that patient that has a moderate MELD. They have ascites, they have some encephalopathy, they have difficulty living an everyday life. There's sort of a chronic illness there. And, we can see from Whitney's work that living donation would be an ideal scenario for them. There's a lot more work in perfusion. So in addition to NRP, we're now doing machine perfusion. Okay, and that's something that, it's a topic for another talk or maybe an additional talk, but we are taking a lot of marginal allografts, putting them on ex vivo machine perfusion, and very similar to the way we do with NRP, we can assess the viability. We can see if the allograft is going to start to work, have some reassurance, and then move forward with transplantation. So a lot of the programs that don't have a robust living donor liver transplantation are now using machine perfusion to target those patients on their list that are low to moderate MELD. And there's, we're starting to do more transplants, and that's a very effective way. So one of the debates we had at our controversies meeting was, hey, how do we take care of our moderate MELD patients? Do we do living donor, or do we use these more marginal allografts that we're putting on machine perfusion? It's also an opportunity to, while the organ, whether it's a kidney, heart, lung, liver, is on ex vivo machine perfusion, normal thermal perfusion, that is an opportunity to deliver a targeted therapy, right? You can use an anti-inflammatory. We've recruited a surgeon from Cincinnati who will be coming later this fall, who is actually using lipid nanoparticles to deliver mRNA to the endothelium of a kidney while it's on machine perfusion to take down the MHC proteins and try to induce tolerance. And so, to answer your question, I think over the next 10 years, I think that's where the next needle will be pushed forward, is trying to use machine perfusion in a way that rehabilitates allografts, okay? And then makes some of the more marginal ones now usable, making our long-term outcomes better, okay? And then, we can talk about xenotransplant. I think there's a lot of excitement about it. How long that'll be before we have a durable answer in xenotransplant for our recipients, I think we're still a ways out, but eventually down the line, that's something that may significantly change, that donor gap, and us being able to just move forward with transplants to anybody who has early indications.
Thanks. Other questions?
Thank you for the super interesting talk. One of the things that strikes me a lot participating in the transplant center is just something that you highlighted, which is the really nice collaborative spirit between surgeons and medical specialists and so forth. I'm also struck that I know a lot of the medical subspecialties are having a hard time recruiting people to go into transplant as a subspecialty. And I was curious if you could say a little bit more about your thoughts, vision for the transplant center of how do we make this an attractive place for people to come? Like make it the part of the specialty that people want to join? What does it take in a transplant center to really grow the field in that regard?
It's a great, Montague, that's a great question. I think that we need to really double down on the teamwork that is evident in transplant. Some of my best friends are hepatologists and our nephrologists and the people we work with every day. And we need to double down on that and recruit people to this field. There's the machine perfusion is going to help with recruiting surgeons because, there's this idea that all we do is operate in the middle of the night. And, it has been that way for a long time. Now we can put organs on perfusion and start the case at 7:30. So I think that, as we make advancements in this, we will improve our recruitment of young, bright surgeons. The Department of Medicine and, Vineet and Eddie are working very hard to put together a division of transplant medicine. And so again, we're innovating here at the University of Colorado. The transplant hepatologist and the transplant nephrologist have a lot in common. Probably, maybe more in common with each other than they might have with their other divisions. And so bringing them together so that they can all essentially collaborate and we can, work together to, push all these different organ systems forward together, I think is a very thoughtful and innovative way to look at transplant medicine going forward. Again, Colorado is, we're gonna do that, and we're gonna be one of the leaders in that. And again, it's a great collaboration between medicine and surgery and the hospital.
Thanks for a great talk. Two questions. One, did I see that for robotics that it was still a 6% mortality? I think I'd seen it was compared to an 18%, but just kind of wondering what thoughts are for donor mortality and if that's changed over time.
I think that was the recipient side.
Okay.
Yeah, I mean, we can walk back through that, but
more reassuring. Okay.
Yeah, no, the donor mortality in their series of almost 1,000 patients is 0. There's only been a handful of donor mortalities in the United States since 2002.
Glad I misread it.
Yeah, so that was actually, and I should have pointed that out. That was, the recipient mortality was significantly lower for patients that received a living donor from a robotic recovery.
Got it. Thanks. And my second question is related to split liver donation.
Mm-hmm.
And certainly we're doing half for living, but for deceased donors, I was wondering if you could talk a little bit about evolution with that, especially with some of the newer technologies.
This is a good, I mean, using split livers is an opportunity to expand the donor pool. The way things are set up right now is that a recipient gets an offer and it's essentially their liver. And so it's up to the transplant center to say, hey, I think this is something that we could split. But what you're doing is you're increasing the risk to that recipient now by using a partial graft. And so there are a lot of initiatives, especially in pediatric liver transplant, to try to split the liver. So it comes back to, high level policy. What do we want to do? And so, we're going through a big change with OPTN and UNOS right now. There's a modernization, but somehow incentivizing transplant centers that have the expertise. We're one of them. to do that is, the challenge. There's potential there. But if the way it's set up now, if your recipient has primary access to a young splittable liver, it requires me or a surgeon, one of the hepatologists, to go to that recipient and be like, hey, we have this perfect liver for you. Are you willing to undergo a split and share it? And a lot of people are, okay? And so right now, we've done several splits in our program recently, but it's the pediatric side that has the primary offer, and they literally can't use the whole liver because it's too big. And so when we split it, then there's a half that is usable. And if it's usable for an adult and we have a relatively small recipient and it's big enough for our recipient, then we bring it back over here and do that. I went into this because the operations are amazing. We take a patient who's super sick and they get better very quickly with a technically challenging, elegant operation. I had no idea how much policy and national and now even international oversight that there is in transplantation, right? I can't just take any liver I want and put it in any recipient. There's a whole structure there to make sure that this scarce resource is used wisely, but it's a big, arduous system. And so there are a lot of people clamoring for exactly what you're talking about. We need to do this, and we need to accept the risk, and we need to normalize to the recipient that's getting the offer that, you have a great offer, but there's this caveat that there's going to be slightly increased risk of a bile leak or a problem with the vascular hookup because we need to split it so that we can take care of another recipient.
All right. Any final questions? All right. Well, I just want to thank you so much for coming. This was a wonderful opportunity to learn more.
It's an honor to be here to give this lecture. Thank you.